We'll just do that. So thank you so much for taking time out of your really busy week to come hear my presentation. I'm super excited to talk about my research always. And I titled this presentation, What's My Population Again? Which is kind of just an homage to a question that I feel like I'm constantly asking myself and other people are asking me. So in this presentation, we're doing two things, kind of describing my journey and finding my niche, and also share some research findings and some future directions of where I'm going to be going. So my research program, which has been changed here and there, and words have been added and words have been cut out. Basically, this is like the bare bones of what I'm all about, and that's improving communication during treatment decision making. It's something I became really passionate about as a critical care nurse. I couldn't believe the types of decisions that we had in the ICU, mostly families, making for patients. A lot of times it was kind of life or death types of decisions, and so that really got me interested into how these decisions are made and the whole process of treatment decision making. So I did my dissertation work looking specifically at surrogate decision making in the intensive care unit during family conferences. And family conferences specifically are when families and the healthcare team get together to decide what would be best for the patient and what kind of decision they're going to make. As I mentioned, a lot of times it involves withdrawing care or continuing a more aggressive type of care that would lead to really aggressive rehab. And in doing my dissertation, I talked with Doug White from Pittsburgh, who's kind of an expert in the field. And one of the things that he told me, oh, this sounds good, your work, it's really exciting, but, you need to start thinking about your niche of where you fit in this. There's a lot of people who study this. It's recognized as a huge problem, and so everyone's trying to fix it. And so what about your research is different, and how are you really going to be making a contribution to this field? Which I thought, that's a great point. And so I just kind of put that in the back of my mind as I continued through, graduated, and went into my postdoc. And during my postdoc, I was I was in a different institution, and I was just thinking about my next steps. I had focused on communication during my dissertation, so now I was trying to say, okay, I have all this really interesting communication strategies that I identified. Now let's see if it actually leads to outcomes for surrogates. And in particular, I'm just looking at outcomes such as decisional conflict. Are there certain ways that people communicate that could lead to less decisional conflict for surrogates in making these decisions? So I met with stakeholders in the ICU, which are pretty much nurses in the intensive care unit, some nurse managers as well. Told them my plans about how I was going to auto-record family conferences, collect these measures from surrogates. And they were really excited about what I wanted to do. They thought it was really important, but they're just kind of like, we hardly have these conversations here in the ICU. It's something that nurses recognize as being really important, and it's something that we talked about here and there, but family conferences really don't happen that often in this institution, which I was like, that could be a problem. So I had that kind of in the back of my mind, and I was working with a lot of people in the GREC. So I was talking to some experts in older adults and a lot of, yes. Yeah, so the GREC, I'm looking at Tanya. The GREC is the Geriatric Research and Education and Clinical Center. Yeah. All right, so there is a focus on older adults, and that's where my office was for my postdoc. So I was surrounded by experts in older adults research, and in particular, a lot of them were also experts in dementia. And so one of the things that people kept bringing up to me is why not focus on individuals with dementia? It also have that surrogate decision-making component to it, and it's something that I personally have some passion about from family. Alzheimer's is kind of really prevalent in my mom's side of the family. So I thought, yeah, this could be my thing, right? And I got really excited. So the next thing I did, of course, was a review to see, let's see what's been done in this work. So I did a scoping review of the process of decision-making for patients with dementia and acute care. And a scoping review is a review that can be done before a systematic review to kind of see if there's even enough out there to do a systematic review. So it's kind of just like a prelude sometimes. And I wanted to focus on acute care still, because my passion is still what happens in the hospital. Because a lot of nice work happens in the outpatient setting, but then when people get to the hospital, the whole train kind of goes off the track. So that's something I still really wanted to focus on. And you can see my inclusion criteria for this review. I was looking just for primary data. Again, in acute care, it involved patients with Alzheimer's disease or other dementias. And I really wanted to examine the process, factors, or experiences or interventions pretty much what that leaves out are any type of hypothetical scenarios. So there's a lot of work out there looking at, well, if you had a patient in this type of situation, what would you do? And I wanted to just focus on what we know of people who actually have experienced this, what they've gone through, and how this process actually works. So we identified 28 articles in this review and put them into categories using inductive content analysis. And some of the categories were expected and things that I've seen in other populations and end of life for ICU decision making, such as culture and systems have a lot to do with how these decisions are made. Context definitely matters. There's a lot of issues around role clarity. Surrogates don't really understand what their role is in making the decision, how much authority they have. Physicians, actually, there's a lot of role clarity about how much authority they have in making these decisions, even across different countries where the authority is different legally. And nurses really have no clue about what to do in these situations. And of course, caregivers need support in making these decisions because it's really difficult and a complex situation. But there are a couple of things that I recognize that I feel like were really more specific to individuals with dementia that I found interesting. One was the sense of knowing the patient just became really important in making these decisions. So there's talk about having advance directives, potentially, what to do when there wasn't advance directives, what to do when there was an advance directive, but they felt like what was in the advance directive isn't necessarily what they wanted to do or would be best for the patient, so when those things conflicted. Things that were really specific to dementia was knowing the patient's baseline, so how they usually are at home versus now how they are in the hospital, and how those things differ, and whether or not they're expected to continue a decline or they're going to get back to that baseline. And then one of the things that we did in our scoping review, the scoping review has, there's different ways to do it. We followed Arksy and O'Malley's way. It has 6 different steps. And the last step of the scoping review is considered optional, but of course I wanted to take the option, and that's to do a consultation with stakeholders of the phenomenon that you're looking at in your review. So we did this at a very small scale. We just looked at healthcare providers of people who had provided care to dementia. And we showed them the findings of our scoping review and asked them, so what do you think about this? How does this fit with what you've seen in practice? And one of the things they kind of kept coming back to is when somebody is with dementia is in the hospital and the decision needs to be made, lots of times people are reaching out to the primary care provider, the person who knows them best, who knows the family best, who has a really good understanding of the situation, who has been with them for sometimes years and years and years. So this big sense of knowing the patient that I didn't experience as an ICU nurse for any other type of population, it seemed pretty interesting for dementia. And then the other piece of it was the appropriateness of palliative care in dementia was really interesting. So there is a sense out there that we already have limited palliative care resources or hospice resources, and if we have everybody with dementia in palliative care, there wouldn't be any left for anybody else. So there's kind of this debate about whether or not people with dementia even should receive palliative care, or it should just be recognized as kind of a normal trajectory of the aging process. So that was kind of interesting as well. And then I noticed a gap of the literature was that none of the articles involved any type of audio recording the actual interactions, the actual decision-making conversations at the bedside. So for me, that was like, yay, because that's kind of what I do. I use, my method of analysis is conversation analysis, and that relies on all the data to be either audio recorded or video recorded data. So I was really excited that I could really make a difference. I found my niche, I'm ready to go, and I was excited. So my next step was to design my study. And so I decided to audio record provider, older adult, and or family conversations that happened during daily rounds, goals of care conferences, and on admission. So listening to the people at the institution that they don't have a lot of family conferences, I wanted to include, okay, they have to talk to patients or family at some point. So when do any of these conversations happen? So I included conversations that happen during daily rounds, because that's always when people are talking to each other, hopefully, as well as on admission. So when a patient just comes into the emergency department, these might be conversations where they actually talk about whether or not the patient wants to go to the ICU, whether or not they should be going to the ICU. So I felt like these were really important. And then I changed the language from family conferences to goals of care conferences, recognizing that some of these patients would be able to make their own decisions. And so in those situations, it's more just called goals of care conferences and not family conferences, even though family might be involved. So I kind of changed a little bit of where I was collecting the data, but still focusing on communication, still audio recording conversations. And then I had a pretty ambitious aims list. The first was to identify how providers and patients and or their caregivers communicate about treatment decisions in the ICU, emergency department, and on inpatient wards. So I decided to broaden it, so not just looking at ICU, but kind of everywhere in the hospital, again, to capture conversations about whether or not even to transfer to the ICU or continue care in that way. And the first sub-aim, 1A, talks about quantifying that data using transitional probabilities, which I'm not going to get into too much because I don't have that data quite yet. Then aim 1B is really that focus on dementia, to trying to evaluate that communication and seeing if it differs between individuals with dementia and individuals without dementia. I had the wherewithal to know that I probably wasn't going to get a big enough sample of just individuals with dementia, but it was something I wanted to look at, and I thought it'd be kind of interesting to compare them to each other. There is some literature out there to suggest that individuals with dementia, when they arrive in the emergency department, even if they're in the early stages, even if they're able to make their own decisions, are a lot less likely to be asked their preferences for their care. So I wanted to kind of see if there were differences such as that in these conversations. And then my last aim was to determine how previous advanced care planning is introduced and discussed in treatment conversations. This kind of came about for a couple of reasons. One, this institution has a really robust outpatient advanced care planning program. And so it was kind of like giving back to them to just show how these documents are actually being used at the bedside in these conversations, how they may or may not be directing care. And that's something that actually is a huge gap in the literature as well. So some outpatient, really community-oriented programs, such as like Respecting Choices. I've done some work with Respecting Choices, and it's pretty much limited to chart reviews and seeing if a patient has an advanced directive. But it's a big gap in the literature of how exactly that's being used at the bedside. So I included that as an aim as well. And I would like to acknowledge I got funding from the Research Committee Award at the School of Nursing. So my sample, I had a goal to include 50 provider, patient, family conversations, and I recruited by following 2 medical teams, and they changed every 4 weeks, which was a little problematic because I feel like I kept having to come in and reintroduce who I was and what I was doing. So in some ways that was good, and in some ways it made it a little bit tricky. And I wanted to just restrict to older adults, hoping that they'd have kind of more complex hospitalization, and so even if they were having kind of more mundane conversations just about what's going on with them in the daily rounds, they would still be complex enough that it would be kind of an interesting conversation. As I mentioned, audio recording during daily rounds, on admission, during goals of care. And this is a mixed method study. I'm not going to talk too much about event sequencing, which is the quantitative portion of this, again, just because I don't have that data right now. I will talk about conversation analysis, which is one of my favorite things to talk about. So it's a qualitative method, but it's different from other qualitative methods in how we think about it, in that you look at the conversations and your focus is on the actions of the utterances. So what they're doing in the interaction versus what they are about. So I'm not looking at themes, I'm not looking at topics, but I'm really just looking at how this utterance leads to a responding utterance, and then that responding utterance in the conversation. So how that interaction becomes structured. And one of the things that I'm looking at in particular is how the design of an utterance, particularly provider utterances, can really lead to how patients or families respond to those utterances, because the design of an utterance matters. And if you're at all skeptical about this, I have an example from my data. This was a conversation that happened during daily rounds where the physician brought up code status. So he brought it up in this way. A lot of times we ask people, what they would want us to do if we came in here and if you had died or passed away settling on us, what are your thoughts on that? And after a pretty long pause, the patient said, well, I guess if you could bring me back to life, I'd rather live than die. So here's a situation where the design of this utterance probably had a lot to do with that answer. If the physician had just stopped here and said, okay, so we'll put you in as full code, we'll put it in the chart, we'll have your wishes kind of documented, this patient would have been a full code. But instead the physician kept going and said, yeah, and that's what most people say. I'll tell you though, in your situation with everything you've got going on, the chance of you surviving, that's probably around like 3 to 4%, pretty poor odds. And if you did survive it, almost certainly you'd be in a nursing home for the rest of your life. I just tell you that because we don't do a good job of telling you. Most people say I want to live, but we don't do a good job of telling you what living looks like after that. which is probably with a lot of tubes and you living in a nursing home, to which the patient replies, yeah, I really don't want that. So here you have the same patient in the same situation. Context is all exactly the same. The only thing that's changed is just the design of how this is being approached and brought up. And it completely changes the patient's decision of what they want regarding code status. So it's an interesting method to kind of look at those types of subtle intricacies that actually have a major impact as to how the conversation goes on and really as to how people decide what they want to do with their treatment. And you'll notice that these transcripts are, there's a lot going on. So just to orient you a little bit, the numbers that you see here are pauses, and they're measured to 1/10 of a second. So it's, some people do it with computer systems, and other people just kind of do it by counting, but it's measured to the 1/10 of a second. And then other notations point out how something was said. So the goal of these transcripts is really to try and someone can read it and almost hear it in their head. So there are things like emphasis by the underlining, stretching of vowels you can see with the colons. Not in this example, but there are some where there's upwards arrows or downwards arrows, which show change in pitch. There's indications for overlapping speech we don't necessarily have in this example right here. So it's really kind of a robust way to capture these audio recordings and study them with all those little details that can make a really big difference. So before I show you what my results are for the entire study, I have to kind of pause and say that they've changed quite a bit. My goals and my whole strategy has had to, well, I'll say they had to shift due to some issues I have with recruitment. One, I haven't been able to recruit any participants with dementia. One of the issues the institution is really stuck on having written consent, and a lot of patients with dementia don't have a POA at the bedside, and so they're unable to sign a form. Whereas in the study I did previously, I could call them on a phone and I got verbal consent, but here they need to actually sign a form. So that's been an issue. And there have been some individuals with dementia who are early stage and are able to consent for themselves, and I talked to some of those patients and they've all refused to participate, which is kind of interesting. Also haven't been able to recruit AA participants on admissions. It's a bit of a logistical nightmare, but then again as well, then there have been opportunities where somebody meets the study criteria and I have gone to talk to them, or a member of the healthcare team has gone to talk to them. They refuse to participate, which again, perhaps isn't so surprising. They are experiencing an acute event, they're stressed out, there's a lot of people going in and out of their room, so not surprising that they don't want to talk to me about doing a study. And again, not surprising based on the feedback I got from individuals at the institution, I haven't recruited any participants during goals of care conversations. So my refusal rate for this study is pretty high. It's about half the people who either I contact or a member of the healthcare team contacts say no. It's higher than what I was expecting. In my previous studies of surrogate decision making in the ICU, it was only like 35.7% to be completely accurate, which was interesting to me because I think that those kinds of conversations are a little bit more intense and there's a lot more higher stakes going on in those conversations than just during daily rounds. So I wasn't expecting that high of a refusal percentage. Some reasons that people have given to refuse, patients usually don't say a lot. They usually just kind of be like, oh, I'd rather not, but thanks for coming. They're always very nice. I haven't had anybody yell at me, that's for sure. But they're just, they got enough going on. They just don't want to be bothered. Providers oftentimes don't feel comfortable, especially if they're kind of new to their residency, they're new to their intern role. They just don't feel comfortable being audio recorded. And there's been a lot of provider gatekeeping as well. So it's been interesting, some of which has been, that person had a bad day, or they just received bad news, so I don't want you going in and bothering them and talking to them. But a lot of it, probably most of the gatekeeping that's happening is, oh, you don't want to talk to them. Like they're really crabby, they're really angry, they're going to say no, don't even bother even going in that room, which is interesting. And sometimes I probe that a little bit more, and I think a lot of it is just the person's already kind of upset and annoyed with the care that they're receiving, and they just feel if they have somebody else kind of enter that situation, it can make it worse for them and their relationship with the patient, which I also understand a little bit as well. So there's a lot of dynamics that go on, a lot of logistics, and just everybody feeling comfortable in the room to get these things audio recorded, which is a bit of a challenge. So with that in mind, the current state of the study, without people with dementia, I lose that aim, and without any discussions on admission or goals of care conversations, I haven't had any discussion of advanced care planning documents, perhaps not surprising, during daily rounds, so I lose that aim. So I am left with 1.5, which is just identifying how people communicate about treatment decisions. But it's okay, I got good data, I'm okay with it. But just FYI, things just had to shift a little bit. So my current recruitment is 35 provider-patient interactions that happen exclusively on daily rounds up to this point. I am optimistic that I will get to 50, or at least very close to 50 by the end of the year. So now shifting to show a little bit of my results. These are some of the demographic characteristics. Most of the people who participate are younger. They're closer to 65 in their mid-60s. Majority are male, majority are white, and the majority have at least a high school diploma or GED. And the majority have an advanced directive, as indicated by that really intense outpatient program that they have going on. Having 30 out of 35 with an advanced directive is quite a bit. And these numbers don't add up. There are a couple of people who refuse to give me this information, which of course is fine. So the structure of these conversations that happen during daily rounds usually start with some type of greeting between the provider and the patient. And then they go into this list, is what I'm calling it. And that's where the provider starts with like the rapid questions. You having any pain? Having any shortness of breath? Are you eating okay? And of course it changes depending upon who the patient is and what they came to the hospital for. But just kind of going through that list of things that they're wanting to ask. And then it shifts to the plan. And the plan doesn't necessarily have to be anything, broad, big scheme, big picture plan. But it's really just when people are in the hospital, there's a plan to get them out. It's never just a plan to keep them in the hospital. There's usually a plan to get them out or to have their condition progress in some way. So there's always a plan every day of how to do that. And then, of course, there's a closing. So I'm still in the early stages of my qualitative analysis with conversation analysis. And just in this kind of stage, we do what we call noticings of just looking at the data and seeing what's interesting. So I'm looking at, my aim of just seeing how treatment decisions are made. But within that, just kind of seeing what seems to be interesting, what kind of jumps out at me. And my first observation that I've noticed is that patients actively work to negotiate the plan of care, often through sharing concerns. Of my 35 conversations, or I should say, of 25 conversations I've analyzed thus far, patients have shared 73 concerns. So it's something that is brought up a lot during these conversations. In only one conversation where there are no concerns shared. So pretty widespread that patients are sharing these. And a lot of times they work to negotiate the plan of care. So where these things happen, during the greeting. So greetings are oftentimes, how are you feeling? How was your night last night? How did you sleep last night? Sometimes that could just be treated by the patient as a greeting, of just kind of like, oh, I'm good, I'm fine. And then they start asking questions, you figure out that they're not fine. In some cases, actually, providers will be like, how was your night last night? And the patient's like, oh, I'm good. And they'll be like, was it really good? Well, no, actually, no, because the provider already knows that something happened overnight. So that's been kind of interesting. But sometimes patients really do take that opportunity to be like, no, I didn't sleep last night, had a lot of anxiety, I'm worried about, I know I'm getting discharged today, I don't know to what facility, and that's really bothering me, and I couldn't sleep about it. So they just jump right in with these concerns that they have and are already negotiating kind of where they're going and what that's going to look like. Most of the time, this happened during the list section, where providers would say, are you having any pain? And someone might say, yes, I'm having a lot of pain. And then they start negotiating how to address their pain management plan. Something that's kind of interesting is we've noticed some patients actually reorient providers from their own list, whereas a provider will say something like, are you having any chest pain? One patient in particular was kept reorienting to congestion. So you're having any chest pain? And the patient was like, no, I don't have any chest pain, but I have this really awful congestion, and it's really bothering me. And, and then the provider's like, okay, well, we'll make sure that we, think about that and how to address it. And then, are you having any shortness of breath? No, I have no shortness of breath, but I have this cough because this congestion is just really bothering me. So constantly trying to get back to what the patient wants to talk about and what the patient really wants to focus on getting addressed that day for sure. And then the plan is kind of where I have most of my examples I'm going to share are really about negotiating the plan and where concerns about the plan get brought up, where patients just disagree with the plan or share concerns about how the plan is presented. And then lastly, closing. Hardly any concerns are brought up during closing, which is interesting because that's usually the time when providers ask, do you have any questions or concerns specifically? And by that time, though, patients have already aired their grievances. somewhere else in the conversation. So by the time they get there, usually they don't have anything else to bring up. Sometimes they do. In 7% of the cases they do, but usually it's happened before in the conversation. So conversation analysis isn't necessarily about topic, but I'm still a nurse, so I'm interested in the topics of like what these concerns are about. Not surprisingly, the first 4: symptoms, placement or whether or not they're going home, procedures that they're having done, airing grievances about some personnel that they're not too happy with. And then finally, what I find really interesting is the family responsibilities or concerns. A lot of times, the reason to negotiate the plan of care isn't necessarily the patient's symptoms, but it's more about whether or not somebody who's going to be their caregiver at home can deal with those symptoms. Or there are times when, I have an example that I'll show, a patient is a caregiver for a spouse, and so they just, they have these other responsibilities that really affect how their treatment plan is going to look in the hospital. So I'll tell you these observations, then we'll go through some data. So sometimes the plan is presented as options where providers will say, okay, do you want to do this? Do you want to do that? But sometimes the plan is just kind of presented as a matter of fact, and patients outright reject the plan and say, that's just not going to work for me. Either way, physicians and patients are oriented to this notion that it's all a negotiation. And so with that in mind, physicians seem to really be delicate, and they use different designs when they're expecting resistance from patients. Whereas if they just feel like they're doing the standard of care and it seems like it wouldn't be problematic, they design things differently. So I'll show you what those look like. So starting with negotiating going home. So here's an example where this was the patient actually kept reorienting back to congestion. And so the providers are trying to talk to him about when he'd feel comfortable going home. So here we have, and it starts out, she had just asked about they had changed a medication that he was on, and that was going fine. So that's kind of how that starts out. But then she says, so can we talk a little bit about kind of where you'd like to go at this point, like whether you'd feel better staying in the hospital a few more days, whether you're more interested in going home to your brother's, going to a different hospice facility or arrangement. Before the hospitalization, this patient was at home hospice with brothers taking care of him. The patient answers, maybe stay in the hospital until I can get this congestion broken up. So again, brings out this congestion. You got to fix this congestion. And then he says, if that's okay, I know. So here, there's an orientation to he's able to make this decision, but still recognizing that physicians have some authority that he may or may not be able to kind of step on. So saying if that's okay, just kind of I think harkens to that idea. The provider continues saying, so that's the main thing for you to kind of want to stay in the hospital for right now, to which the patient replies, because my brother, he'd probably, if he had to deal with me being down, he'd probably panic. So here's an example. He's got these symptoms, and his big concern is he doesn't really think his brother's going to be able to handle the symptoms that he has right now. And after this, he tells the story about how he got to the hospital because his brother panicked because of all the symptoms that he was having. So that's how he got to the hospital initially. And the conversation continues after telling that story. Physician says, yeah, that makes a lot of sense. So, it looks like trying to get arrangements in place and take care of your pneumonia symptoms. We might have you in the hospital another day at least anyway. But how long would you kind of be wanting to stay here? I guess given the pneumonia resolving, maybe within the next day or two. Patient responds, well, if you could resolve the pneumonia and I'm not bleeding out again and we get dialysis arrangements in place that are solid, I'd be all right with going home then. So here you can see there's a lot of negotiation about where he's going, if he's going home, and even when he's going home. And he's even saying, well, if you address these things, okay, I'll go home. So there's a lot of negotiation and patient agency here. Another thing that I keep noticing is how palliative care is addressed, which of course is near and dear to my heart. It's very delicate, and it's something that I've seen in other studies as well. But even on daily rounds, just mentioning having the palliative care doctors come see somebody is a super delicate thing to bring up. Nobody just says, okay, and then we'll have palliative care doctors come to see you, FYI. It's always done with a little bit of delicacy and a little bit of back and forth. This is the most extreme example of bringing up palliative care that I'll share with you. You can see how long it is. So the physician, I'll try to read it the way that he said it. And then the only other thing we wanted to touch base with you on is, we were, with your permission, going to get the palliative care doctors involved. Okay, and I think, where what we really just want is, from our side at the very least, I'm not quite sure if that's, you tell me if you agree or disagree, is that we just want to have a good goals of care discussion, which I think you've had before with these doctors. And I think they'll know what they really do is, I'm sure you're aware, is that they kind of combine trying to make sure that your wishes are being respected. And then says, do you have any questions about that? The patient says, no, I don't. Are you okay if we get them involved today? The patient says, sure. So you can see this is just so almost painful. You can see how delicate this is. There's a lot of hedging going on. There's a lot of pauses. There's fast speech with slow speech, and just double checking if it's okay with you. And I don't know if you agree or if you disagree. And even after going through all of that, just double checking, do you have any questions about that? And are you okay if we get them involved today? So just constantly looking for acceptance of doing that. It just shows how this can be a delicate thing to bring up, because it could be an area where there is resistance from patients and even talking about palliative care. So these next couple of examples are instances where it's more patients or physicians just kind of talk about things like, and this is what we're going to do next is kind of just the standard of care, no big deal. So you can see that's a lot different in their design, how they're designing these utterances. So one of which is weaning oxygen. The provider says, all right, well, we'll see how you do today. We're going to try to wean you off the oxygen. Okay, see how you do. And there's a 2-second pause here. And usually, one of the reasons why it's important to measure pauses, anything over a second, 2 seconds especially, means that, okay, there's a problem ahead. There's resistance coming. And the physician's oriented to that by being sound okay? You have any questions for me? Come on, how come you're not just agreeing and we can move forward? To which there's an even longer pause, which is just okay, danger. And the patient says, wean me off, I'm down from 6 to 1, which of course 6 liters to 1 liter. The provider says, yeah, you are, but you're usually not there. But now I got to go to 0? Well, you're usually at 0, right? You don't use oxygen outside of here. I need outside of here, that's the problem. Actually, you've been on 0 for the last 10 minutes, and you're at 96%. That's because I've been hyperventilating while taking a fluid drive. And here, all caps means shouting. So at this point, we're already got yelling going on. And the physician says, it's all right, well then also your oxygen at 88% is actually okay for you. This patient had COPD. The patient says, that's ridiculous. So this conversation actually spiraled downhill from here to more shouting and actual name calling. But just a very, negotiation of really was unhappy with this plan of weaning off the oxygen. Even though the physician seemed to be oriented of yeah, this is normal, this is all good, not okay with the patient, and was pretty vocal about that. Another example in getting a patient a stress test while in the hospital. No, we'll let you know the results of the stress test when it comes back. If it gives us results that we need to do something about, then that keeps you here for at least another day or two. The patient immediately, has resistance to that. I got to get home. My wife is alone, and she's worse off than I am. I take care of her for getting her meals. When do you have to be home by? I should have been there this morning. She had to go to get off to it. This kind of stuff means that we don't really necessarily know what they're saying. He kind of trailed off there. But then he says, I hope she found someone to take her over to the clinic. So here's an example where this patient might have something really serious. He's going to have a stress test, but whether or not he's going to receive that stress test or the kind of care he receives in the hospital, really trying to negotiate by, hey, I have this responsibility. I'm my wife's caregiver. I don't know how she's going to get care if I'm here in the hospital. So there's all these issues that he's trying to have to deal with, and he's trying to negotiate how to resolve this with the plan that the providers kind of just put out in front of him as standard of care, normal business. You get the stress test, you might have to stay. This one's my favorite. I'll call out right now. So this was a patient who had an infection in his leg. And so the physician team, what they wanted to do was they cultured the leg, and then they were going to kind of wait and see what type of bacteria it was to match it to the right amount of antibiotics. And the alternative to that would be to have a patient receive or just get an amputation of the leg. So the physician, we're going to call down to lab today and say anything growing yet, see what they tell us, okay? Again, long pause, 1.5 seconds, so trouble ahead. Patient says, I think it's a lost cause personally. I can live with one leg. Physician says, I think that we can keep trying, but I know that you're kind of going towards that surgery route. And then he says, I only got a good 10 years in me left. I ain't going to spend it at the doctor. Provider says, why do you say that? I'm going to be 70 years old. I ain't got a lot of time left. Not in my age. And then he kind of goes on. Provider says, well, other than the leg, you're pretty healthy. Then the patient starts talking about the oxygen. He starts laughing. There's a lot more there yet. Physician says, well, we'd like to give you as many years as we can. Patient says, yeah, I got a right knee that's all screwed up, a right hip that hurts, my back's screwed up, the sciatic nerve makes my leg go numb, I got to deal with this, I got enough to deal with that. It's a lot to deal with. Yeah, 2 years. I got to give everything up I like to do. I thought I could get by, then this shows up. So this is a really kind of lovely conversation that I think we would all love to have happen at the bedside. And I'm not entirely sure it would have happened if the patient didn't just start talking about this. There's nothing really that the physician said to necessarily incite a discussion about quality of life or about that as far as treatment options. Didn't really give a treatment option. They were just going to call the lab, and that was going to kind of be it. So this again is really interesting how patients are really starting to have a lot of agency and being very vocal about when the plan doesn't work for them and how they really see the plan working for them even after the hospital, what their quality of life could look like. And as I was looking through my data and seeing this kind of over and over again, one of the things that I thought about was, one of the things that I thought about was Anssi wrote a paper 20 years ago. Anssi Perikkala, he's in Finland, and he does conversation analysis. He is a psychosocial linguistics or something like that, but he does conversation analysis, and he wrote a paper on medical authority and accountability. And in that paper, he kind of talked about how things have changed, how we think about medical authority over the years. So going back to, of course, Parsons in the 1950s, saying the layman cannot judge physician competence, needs to take judgments on authority, you just never question your physician. And even in the 70s, delivery of diagnosis in primary care, which is what he was studying, physicians did not give a diagnosis, but they simply just told the patient what the treatment was going to be. So it was just very physician, there wasn't a lot of back and forth going on. And then in the 1980s, I guess, Shorter had written that patients already know what medication they need before going to see the doctor, who shop around the market of alternative medicine, who are unwilling to accept the doctor as a priest or medicine as a series of holy rites. Which I find interesting that this was already going on in the 80s. And in Anssi's paper, he noticed in the delivery of diagnosis how that has changed, that physicians gave elaborate reasons for their diagnostic conclusion. So it wasn't just, here's this treatment, it was, this is the diagnosis, and this is why I think it's a diagnosis, and this is how it relates to you. So there's been such a shift into how we think about medical authority. Physicians really need to have accountability for the things that they're recommending and the things that they believe are kind of going on in the patient's world. As I mentioned, I think it's interesting that this was already starting in the 80s, this idea that people kind of already knew what they wanted and what their diagnosis was. That was before Google. That was way before Google. So now, here we are 20 years later, I can only imagine what it would look like in primary care. And one of the things in talking to one of the physician teams after that patient who's really upset about his oxygen, and like as I said, that conversation I think was difficult. So in some ways, I think they kind of wanted to debrief with me about that a little bit. And one person, so we got on talking about Google, and one of the students said on the team, Dr. Google isn't always right. Another student said something that I thought was really interesting, well, Dr. Google's probably right. Dr. Google doesn't have any context. And I think that's a really interesting idea of it's not just about trying to match your symptoms to what a symptom checker is going to say or anything, but really that understanding of context and how that fits in people's lives is really kind of interesting. So in acknowledging this observation, and I know some people are probably shifting their seats and are a little comfortable with what I just said, I will say my next steps are looking at communication, focusing specifically on provider surrogate, again, going back to the surrogates where I do have a lot of love for, during end-of-life and palliative care conversation, anywhere in the hospital. I'm going to be comparing by health literacy. So I do recognize that there may be differences in how people are very active in this conversation. It may be influenced by a lot of factors, and I think health literacy could be a really important one. So I'm going to also be building off my prior work by focusing on identified communication patterns and then comparing by outcomes. And I'll eventually try to use these findings to develop a communication train intervention to help improve our communication with patients. So kind of circling back to my niche, my population, where my focus is with that. I think my niche is less about population and kind of more about this method. I'm one of the few people who looks at conversations this way, who's really looking at this process in this way. There's conversation analysts that do, but they're not necessarily looking to take the next step into developing intervention and making change. And that's kind of where I'm all about, is trying to see, okay, given these really minute details in this conversation, how can we develop a communication training interventions that everybody can be using these and really improving communication that physicians and all healthcare providers have with their patients and families. So with that, I'm right on time. I didn't talk too fast, I don't think. Maybe I did. But thank you, and let me know if you have any questions. Yeah, I didn't have that as part of my IRB. So I would do, to get their characteristics, I'd have them fill out a form. And as I mentioned, a couple people refused to do that. So. Yeah. I mean, I would be interested to kind of try and redesign it to get that admission data that I think would be really important to look at. And it's something I've been working really closely with the teams even. I've altered my recruitment strategy to how to get people on admission. And it's just everything that we try, it's hard. And as I mentioned, even the people who, logistics, all the stars align and it works out, they refuse to participate. So, but that's a good idea to try and get at least some semblance of what that might look like. Yeah, Tracy. Sure. No, I didn't collect anything from the providers. For the most part, they were either, sometimes the med students had these conversations, but for the most part, it was either the resident or the intern. I did have a couple conversations with the attending physician. But I was more so interested in how, just the micro level of how the different designs of the utterances. And so it didn't necessarily matter to me who was having those designs, but whether or not they actually worked in having beneficial responses from patients or families. So that was really more of my focus versus how they differ by different people. Yeah. Sure. All of the above, hopefully, someday. Yeah, probably starting hospital, because that's the most manageable, and actually looking to see the results, of an intervention. It's easier that way. But, eventually I would like to kind of put some of this into, training med students as well, yeah. Sure. Yeah, I think that's a great point. One of the things I try, I don't succeed. I try to get multiple conversations from one person. I do cut it off to a certain extent because I didn't want to have, like 10 from one person in a corpus of 50 necessarily. But the individual, the amputation individual, actually super interesting because I had recorded 3 conversations in a row on daily rounds. And his first conversation was pretty much unremarkable, which is about like pain management. Mm-hmm. What I showed today came from his second conversation where he really got into quality of life. And then his third conversation was very unremarkable, just talked about pain management. So really interesting as to, I don't know necessarily what happened in the second conversation to spark that. And then again, it wasn't really brought up too much again in the third conversation. So yeah, just interesting. Like how, yeah. Mm-hmm. Yeah, so this type of institution serves primarily men, so that's why. There just wasn't a lot of female patients to draw from. It mostly has a male population, so that's, yeah. I was really excited to get some female patients in my sample, so yeah, thanks for the question. Yeah, so there was one in the ICU where a nurse was present, so I got a little bit of nurse communication. A lot of it, and I noticed this in my other study as well, nurses a lot of times just kind of offer clarification, where it seems like there's some confusion between like the physician and the patient, or the physician asks the patient a question and their answer doesn't really answer it, so the nurse kind of jumps in and gives the answer. That was kind of the extent of what I have. Like I said, it was only one conversation where the nurse was actually present during the daily rounds. And there weren't any with a family member at bedside. Yeah, exactly. So I was surprised in that as well, just because, I don't know. When I was in the ICU, I felt like family was always there. But yeah, these were not ICU, of course, so there's the difference with that as well. Yeah. 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 Thanks so much. No, yeah. Tanya? Sure. Sure. Mm-hmm. Right. Yeah, absolutely. Usually, by the time they have that conversation, they have a preference as to how patients choose. I would say, being in the ICU, and I know in this situation, it's like, oh, that patient probably shouldn't be full code, And so how they present it probably is a little bit different in trying to kind of push them towards the DNR route. In my experience doing this, it just seems like every time they bring up a DNR conversation, by the time they bring it up, they're always kind of pushing that they choose DNR. Otherwise, it's kind of just done. This is why I really wanted the admissions conversations, because then it's kind of just routine. Everybody gets asked that, and just to see how that would compare, how that would be different. I was really hoping to get that comparison in particular. That would have been really interesting, I think. So kind of to go to your nursing home comment, I think that was to prevent jargon. So if he was at like an LTAC, a long-term acute care facility he'd have tubes in, a lot of people don't know what LTACs are, but they know what nursing homes are. So I think it was probably why, and there is a lot of emotional reaction to a nursing home, and so I think that was also probably deliberate in choosing those words. Yeah, I would think so, yeah. Did you have a question? I did not, and that's something that I'm hoping to do in my next study, is looking not necessarily at stress, but looking at decisional conflict and making certain decisions. And one of the reasons why I didn't for this study was because a lot of these conversations are on daily rounds, so a lot of the conversations, they're not making big decisions that may or may not be stressful, so that was one of the reasons why I didn't capture those for this. And I didn't really know what I was going to get. I assumed I was going to get most of my data from daily rounds. I didn't think I was going to get all my data from daily rounds. So, I didn't really know what this was going to look like. It was a lot of it's kind of feasibility to see what kind of data I could get. So, yeah, thank you for the question. Well, thank you so much, everybody, again, for coming. I really appreciate it.